Hello, welcome everybody to the session called Daily Highlights by the Asian Pacific Society of Cardiology. We're going to review some of the clinical trials presented here in the ESC and discuss with my fellows, Dr. Kato Park here, and Dr. Kato and Dr. Arintaya from Thailand. So first off, we're going to start with KW's presentation. He's going to review SCORE2 validation in Asian countries. So without further ado, KW.
Okay, thank you, Junya. So these are my disclosures. So this was the study that I'm going to cover today is a SCORE2-ASIA study that was eloquently presented by Dr. Sofian Johar from Brunei on the 25th. So what they did was the SCORE2 study was a risk prediction algorithm that was developed by the European Society of Cardiology. And it was developed in over 680,000 patients and was recalibrated for 4 distinct risk regions in Europe, where it was divided into low risk, intermediate risk, high risk, and very high risk. And it was validated in a cohort of over 1 million individuals from Europe. And the characteristic of SCORE2 compared to SCORE1 was that they not only used cardiovascular mortality, but it was also non-fatal MI and non-fatal stroke was included in the outcomes as well. So the purpose of the SCORE2-ASIA project was to actually test if the SCORE2 model using the same risk factors could be replicated for the Asia-Pacific region. And second was to develop risk charts for 10-year cardiovascular disease risk for middle-aged individuals without diabetes or cardiovascular disease according to regional risk by dividing countries into low, intermediate, high, and very high risk regions as they did in the European countries and doing this in the Asia Pacific. So the target population, because SCORE2 was done in a middle-aged population, it was individuals that did not have a history of cardiovascular disease or diabetes from the Asia-Pacific countries or the Middle East countries aged 40 to 70 years. And the coefficients for the model were the same coefficients that were used in the original SCORE2 in Europe. What they did was they recalibrated the data systemically using nationally representative incidences and risk factors, mostly the WHO non-communicable disease data and the WHO Global Health Estimate standardized mortality rates. And because the data on cardiovascular disease incidence is very heterogeneous across countries, and sometimes the data quality is not consistent among the different countries. They used the cardiovascular mortality and then estimated the total cardiovascular diseases using a conversion multiplication factor. And these were the estimates of the cardiovascular incidence were used in combination with the mean risk factor levels to recalibrate in every region. So first, what they found was that the coefficients that were used in the original SCORE2 model in Europe were mostly similar in the individual data that were gathered from many different countries. As you can see in this graph, the hazard ratio was 1.45 for SCORE2 in the European population, very similar in many of the populations in Asia for age in men. So current smoking, systolic blood pressure, total cholesterol, and HDL cholesterol were very similar to the coefficients that were seen in the European SCORE2 model. Also, by using the WHO Global Health Estimate standardized mortality rates, they categorized the countries into low, moderate risk and high risk and very high risk according to the death rates per 100,000 individuals. And using this, they estimated the cardiovascular disease incidence for the SCORE2-ASIA model based on the multipliers that I described previously. Also, using this, they used the validation cohort from over 4 million subjects and looked at the model fit using C statistics. And mostly the model was adequate fit for the validation cohorts as well. Also, they did a calibration plot for the predicted 10-year risk versus the observed actual 10-year risk, and they saw that the agreement between predicted and observed risk was very agreeable with good C statistics value. And eventually, what they are trying to do is to build a scorecard, as was done in Europe, and replicate this in the Asia-Pacific region as well. So the finding summary is that the feasibility of using the SCORE2 model in the Asia-Pacific was confirmed for prediction of the 10-year cardiovascular risk for individuals without diabetes and underlying cardiovascular disease. Systemic recalibration enabled the use of existing risk models adjusted to the target population, and adequate model fit and agreement between expected and observed values were seen in the validation cohorts. So going forward, the team, Sofian, Stephen, and his team welcomes participation and also welcomes data from as many countries as possible to improve the model, both for recalibration and for validation. Also, because the data set was not available for very high-risk region countries, external validation is especially required for the very high-risk regions. And the team is currently working on risk charts and hoping to complete the project by May 2024 for presentation at the annual Congress in Dubai in 2024. Thank you.
Thank you very much. So what he did was kind of replicate the results of SCORE2 in Asian population. Is that correct?
Yes. So the coefficients that went into the SCORE2 in Europe were used exactly for the SCORE2-ASIA model as well. However, the incidence of the cardiovascular disease was calculated using mortality data and also the risk factor incidence and prevalence data.
Okay. And one other thing. So very high-risk countries, those are not included in this study?
So there is data for the WHO data for the standardized mortality rates and the incidences of the various risk factors. So the multipliers can be calculated. However, I think the problem was the data set was not available from the very high-risk countries. So they actually used the high-risk country data and just used the multipliers from the very high-risk country profiles.
Okay. Any other questions, comments, Arintaya?
I think that the challenges about this could be the heterogeneity for the risk among individual countries, as well as if we use different registry data, the definition of events could be different and heterogeneous.
Yeah, so there is definitely limitations if you go into the individual data sets, but I think the implication and the beauty of replicating SCORE2 in the Asia Pacific is the fact that although we have many different data sets, if you look at the impact of the individual coefficients on outcomes, they are not so different. So it is very difficult for a region like Asia Pacific where, and even Europe, where there are so many countries, we cannot get individual data from every single country that is a very sound data set. So I think the beauty of this effort is to develop a very practical method to be able to have a risk score using the most updated prevalence, incidence data and the mortality data from the different countries. And that enables us to have hopefully a risk scorecard where we can actually see when we see patients from a certain country that this patient is at a certain risk.
Okay. let me move on to Dr. Eri Kato's presentation. She's going to be talking about kind of a follow-up study to this one. So, Dr. Kato, please.
Okay, thank you so much for the introduction. My name is Kato from Kyoto University. So Dr. Park has nicely reviewed the work, so I'm not going to go through very thoroughly. But I first of all would like to congratulate Sofian and his group for this wonderful work on an important one. And to open up discussion, I'd like to introduce some of the work that's done by our colleague in Japan, Dr. Hidehiro Kaneko, who has kindly shared his slides with me. So, and he's one of the leading physicians on this kind of project. So he has noted that there are some distinct differences between European and American versus Asian countries. For example, myocardial infarction is less common in Asia compared to Europe or other parts of the world. And comorbidities is different. For example, obesity is less frequent in Asian, and also there are less cardiovascular death compared to less cardiovascular death and more cancer death in Japan and some other parts of Asian countries. But when he applied the Western risk scores to Japan JMDC claims database, you can see that it works perfectly in Japan population, as well as you can see here for simple 7 and CVD in young adults and hypertension. However, if you look at the discrimination using the Asian SCORE2, you can see that JMDC claims database is somewhat outlier with C-stats of 0.626. So that brings me to some of the points for discussion. So should we be using a different database for different outcomes? And so, as Anita says, Asia is a very heterogeneous population. So, should we be grouping Asia as one, or should we be grouping some of the countries according to social, for example, social economic status, or should we just be using establishing a risk score by country? And also, this was a risk score that used the non-Asian risk score, and it has recalibrated, to fit into Asian. But should we be building a new Asian risk score? And then how about the frequency of validation? So we have seen in this conferences that, GLP-1 receptor agonists, and there is some rise in some new medications, and the practice will change. So how much validation do we have to do, and how frequently do we have to do? And then how about risk scores in special population? For example, there are SCORE2 for older people, and SCORE2 do not include diabetes patients. So do we need a risk score for every special population? So how much dicing do we have to do? And then lastly, what is the clinical implication for this kind of risk scores? So it is very useful and important for example, in starting a new drug or starting or consideration for therapy, for example, starting a statin or something. But there is a limelight for primary prevention, and we are kind of shifting toward starting treatment early and more rigorously. So do we need to apply medication to only the higher risk people, or do we need to treat all the patients? So this is really points for discussion and nothing to criticize or anything. I think Sofian and his group has done a very, very important group, and I have to congratulate once again. Thank you.
Thank you very much. So those are the points. Do you have any comments, KW?
Yeah, so I fully agree with Dr. Kato's comments, and I really think that it depends on the region and the patient and the country. Because I think in more developed countries like Korea and Japan, where we have granular data on our patients and have a collection of data that have really well sorted out risk factors, then I think it may be easier to use that data to internally develop risk scoring for the country. However, even within Asia, the Middle East population is completely different. The Southeast Asia population is different. The Northeast Asia population is different. There are so many different populations that it is very difficult to just use, a scoring system derived from one single database and be able to, generalize that to different countries. I think the beauty of the SCORE2-ASIA effort is to try to bring a very practical system and use a recalibration method to be able to have a feasible system easily developed for many different areas of Asia. And also to allude to some of the points that she made regarding there being a higher MI risk and a lower MI risk and higher stroke risk. The thing with SCORE2 was SCORE1 they used only prediction of cardiovascular mortality, but for SCORE2 it was cardiovascular mortality plus non-fatal MI and non-fatal stroke. So I think the total cardiovascular disease outcome is probably reflected in the score as well.
Very good point. Arintaya?
Yes, so I was wondering if each country, especially developed country, had their own risk score. If we have kind of broad risk score, would that be applied in each individual country? Like in Korea and in Japan, do you have your own risk score system that use widely used?
Was that a question? Do we have our own risk score? So it depends on, the risk scores are mostly developed by different societies. So the Lipid Society, they develop sort of their own risk score, in terms of lipid levels. But I don't think we have this sort of global risk score where because in SCORE2, it was age, it was blood pressure, it was total cholesterol, non-HDL cholesterol, etc. I don't think we have a global risk score currently in Korea for that.
In Japan, there are two risk scores. One is called SWITA score. Another one is, what's that? There's two risk scores. That was implemented in the guidelines of atherosclerosis society. But in clinical practice, it's not widely used. So that's an issue. Are there any comments? Yes, please.
Yeah, thank you very much. I'm Santoso from Jakarta. So I appreciate, I think, for the constructing, the SCORE2 for the Asian population. So I think regarding the incidence of cancer, I think it's more prevalent in the Asia compared to the Caucasian population. Do you think that actually you not only using, the cognitive regression model in modeling, the scoring, but I think should consider the fine and gray model in terms of addressing what is the competing risk beyond the cardiovascular disease. What do you think?
So who's? Okay.
So it is matter of competing risk beyond the cardiovascular disease, addressing the SCORE2-ASIA Pacific. Do you think it is very important, I think, to consider, say, for example, the cancer mortality beyond the cardiovascular disease?
That's an important question. So who can answer this?
I think we do agree that even in non-communicable disease, ASCVD or cancer are important in our region, especially cancer like we have air pollution, we have problem with cancer, lung cancer, something like that. So the risk score for other disease also important. Even in ASCVD risk score, I think the risk factors are different, heterogeneous, and the impact of risk factor. Let's say that stroke, we have probably in some countries we have more hemorrhagic stroke, and in some countries we have more ischemic stroke. That the magnitude of risk factor that include in the model can be different. And I agree with you that the other risk scores should be considered as well.
Yeah, in my opinion, I think this effort should be considered as you have to be able to walk before you run. So it would be nice if we were able to, risk stratify each individual in all of Asia Pacific for all of the diseases, for cardiovascular disease, for cancer, for all of the major diseases. If that was possible, that would be, I think, ideal. But I think currently, if you had a 60-year-old male who is a non-smoker but had blood pressure of 160 and had non-HDL cholesterol, whatever, and total cholesterol of a certain number, depending on where that patient is from. If that patient is from Taiwan or Japan or Korea versus if that patient is from Indonesia or Malaysia or India or Pakistan or some Middle East country, their risk for cardiovascular disease may vary differently. And I think the effort for SCORE2-ASIA is to try to figure out a very practical method to be able to risk stratify these patients so that we at least get a ballpark number to appreciate what the 10-year cardiovascular disease risk is for those patients.
Yeah, I believe that actually the database in the developed countries around surrounding the Asia countries, I think is completely, done. Like in the Japan, Korea, Taiwan, and China, right, compared to the other developing countries. So I believe that all the cause of mortality, I think, are, documented in your fully database. So I'm worried that actually if you are only, say, for example, modeling using the proportional regression model, I think the hazard ratio would be very inflated systematically without considering any other cause of mortality like cancer or other ones. This is the example, and I just want to emphasize that recalibration, I think, is very important for other countries.
Yeah, and I think the important thing is the data that they used is the WHO Global Health Estimate mortality data, and all of the risk factor incidence data is from the WHO non-communicable disease risk factors. So that is updated yearly from national databases of each country. So I think as each country develops and their national data that is reported to the WHO becomes more accurate, I think that the recalibrating process becomes, improves and gets better and better. And one thing to remember is that not only did they look at just the C statistics to see whether the model was a good fit in the individual, validation cohorts, but they also did looked at the agreement between the expected 10-year outcomes and the actual observed outcomes. Of course, the limitation is that they were not able to get data from all of the countries to validate in each individual country. So I think that's where the next step forward is, where the call is to have as much data possible from the individual countries so that they go back and actually validate the model and see if it really works in the individual countries.
Okay, thanks a lot.
Yep, thank you for the question. So we have two more clinical trials prepared for presentation. So Dr. Kato.
There we go. Okay, thank you. So the next trial that we'd like to discuss is STEP-HFpEF. I think this has been one of the most enthusiastic trials so far in this conference, if not one of. So the STEP-HFpEF compares semaglutide 2.4 milligram once weekly to placebo in patients with HFpEF and obesity. So please note that semaglutide 2.4 milligram is for obese patients. It's a dose for obese patients, not for diabetes dosage. And the trial tested in patients with obesity, so without diabetes. And here's the result of the studies. As you can see, one of the primary endpoint was KCCQ, and you can see that there is a significant decrease in improvement in KCCQ, as well as in body weight, and also change in 6-minute walk and change in CRP. And although so here's the outcome that we might be looking for, but the number of events is really small. There were only 14 events, so we have to be careful about the interpretation. But as you can see, the semaglutide, there were only 2 events in semaglutide group, whereas there were 12 in the placebo, and there is a huge difference between these 2 groups. Now, there are more data that has been published just this morning in Nature, so maybe you can look more in details. I'm sorry to say that I haven't been able to look into details, but there are more data. And also, the Novo Nordisk has announced that semaglutide 2.4 milligram reduced the risk of MACE by 20% in adults with overweight or obesity in the SELECT trial. So that is the cardiovascular outcome trial, and that will be presented later this year. So that will be very interesting to see. But then, so there has been a lot of struggle with this drug, mostly from the safety side. But you can see from this slide, this is a drug called lorcaserin, which is a weight loss drug. And as you can see, there were 3 kilogram difference between placebo and lorcaserin. However, it did not translate into cardiovascular outcome benefit. So that brings up to some points of the discussion. So was it the semaglutide, the benefit that we have seen in semaglutide, is it because of the weight loss effect, or is it pleiotropic effect, for example? Is it inflammation reduction? And also, what about the safety consideration? As I have shown you some of the slides from lorcaserin. Now, this drug has been removed from the shelf because of the concern for cancer. So do we need to look for a longer duration for safety signal? And what about the effect in other heart failure populations? So to select, STEP-HFpEF was tested in patients with HFpEF. So what about in HFrEF patients? Or what about in other settings, for example, in adolescent? How far can we go back in terms of primary prevention? And then effect in cardiovascular outcome trials. So we have to look we have to wait for SELECT to be presented, but that will be a trial without diabetes, with obese, and that will be a very impactful result because as you already know, there is similar results from SGLT2 inhibitors, but that is from the cardiovascular outcome trial for SGLT2 inhibitor is within the patients with diabetes. So that will be a very, very different population. So what effect would that have on our clinical side? And then there are other new ongoing trials, STEP-HFpEF diabetes, DM. So that will be tested in diabetes patients. We know that the weight loss effect is less in diabetes patients, so that will be very interesting to see. And there will be SUMMIT trial, which we will be testing tirzepatide in HFpEF patients, so that it's GLP-1 and GIP double inhibition. So that will be interesting to see as well. So I'm just bringing this up for points for discussion. Thank you.
Thank you very much, Eri. Arintaya, so now we are using GLP-1 agonists for HFpEF.
Yes, I think that's very interesting data. I think that the main components of this study is that you have patients that you suspected with HFpEF, and you have the evidence of increased filling pressure to diagnose as HFpEF, and you have obese patients. So the combination of obese causing the symptoms as a main pathology of HFpEF, and you have medication that significantly lower the body weight. And it can reduce other risk factors that can contribute to heart failure. So I think that will be very important data that we can see the significant benefit of body weight reduction in cardiovascular events in terms of heart failure, because it's different from Camellia, which is that in terms of ASCVD risk. It could be different. So I think the body weight reduction has been proved from this study that will help the patient who have HFpEF and obese.
So do you guys think the effect from the STEP-HFpEF trial was because of the body weight reduction? or was it beyond the body weight reduction? What is your opinion, Dr. Kato?
Okay, well, thank you so much. So I think we have seen the reduction in CRP, and that kind of suggests that there is more to GLP-1 receptor agonists than body weight reduction. But I think we are a little bit too early to say anything yet at this moment, because this was a test to really look at the symptom KCCQ and not really the outcome. So we have to do an outcome trial to really understand the effect of GLP-1 receptor agonists. But I'm sure it's coming.
Yeah, I think that's the important part to understand about this study is that it was not a large study. It was a small study of about 500 some patients, but very well done, and it does show that there is significant symptom benefits, from weight loss. I think because obesity itself is a significant risk factor for not only because you are obese as a risk factor for HFpEF, but it has many downstream effects as well. So I think the medication is probably working not only at just reducing the body weight, but I think the disease itself as well, in my opinion.
Question?
Yeah, thank you very much for the STEP half study. So I think anyway that actually this data I think open I think the horizon in terms of dealing with the heart failure with preserved ejection fraction and obesity. So do you think that obesity paradox is still in place in the setting of heart failure with preserved ejection fraction? This is the first question. And the second question, I think we have an issue regarding the cutoff of the NT-proBNP, I think, in diagnosing the obesity with the heart failure with preserved ejection fraction. What do you think?
Who is going to answer this? So you mean obesity paradox is usually used for the patients with MI who fares better in higher BMI, but not for heart failure, I think. Do you think there's a obesity paradox in heart failure patients? I'm not aware of that.
I think that the data has come from heart failure reduced ejection fraction mostly, but in heart failure preserved ejection fraction, I think the obesity is one of the risk factors. And also it can contribute to the symptoms regardless of whether they have heart failure preserved ejection fraction or not. Because if you're obese, you have lots of symptoms that may
except
contribute.
in the heart failure with reduced ejection fraction in the terminal states, I think obesity paradox still there.
Yes.
So what is the issue regarding the cutoff of the NT-proBNP in obesity and heart failure with preserved ejection fraction?
So I think that we know that in obese patients, we have lower BNP and NT-proBNP, and we should lower the cutoff. However, we don't have exact threshold that which cutoff should be picked as a threshold for the heart failure. And I think that any number should be considered as data and should be considered as probability of the patient have heart failure or not in each number of BNP or NT-proBNP.
And I think we can use multiple biomarker approach too. So I think there are more attention on other biomarkers such as CA-125 or GD15, which shows that higher marker is more risk, is higher at a higher risk. So I think there are ways to really show the higher risk using biomarkers, but NT-proBNP and BNP doesn't really work in obese patients. So I think you're right, and we need a better marker. Thank you.
Great question. I'd like to point out that there's no Asian patient included in this STEP trial. So, okay, let me move on to the final hotline session, clinical trials, which is STOP-DAP3.
Okay, the final trial that we'd like to discuss is STOP-DAPT-3 that was presented yesterday by Dr. Masahiro Natsuki and Dr. Hirohito Watanabe. Now, this is from one of my institutions, so I'd like to congratulate Dr. Kimura and his colleagues for such a beautiful presentation and very well conducted trial. So STOP-DAPT-3 compared no aspirin group, which means that they used Prasugrel, they administered Prasugrel 3.75 milligrams per day after loading at 20 milligrams. And that was compared to Prasugrel 3.75 milligrams plus aspirin 81 to 100 milligrams per day. So DAPT versus Prasugrel alone. So the result was somewhat surprising, I think. There were two primary endpoints, one being the bleeding endpoint. So it was major bleeding, BARC 305. And as you can see, no aspirin group did not reduce major bleeding compared to DAPT, as you can see here. And actually, the aspirin group, there was a somewhat increase in aspirin group. So this was another primary endpoint, which was non-inferiority. So it did meet the non-inferiority. However, as you can see, the confidence interval was very high. The high confidence interval was 1.45. It was said to be 1.5, so it did meet non-inferiority. As you can see, there were an increase in number for aspirin group in terms of CV death MI or definite stent thrombosis and ischemic stroke. Now, if you look at the definite or probable stent thrombosis, you can see that there were clear signs of increase in non-aspirin group compared to DAPT. As you can see in the right panel, the hazard rate was 3.40. And if you look at the subgroup of patients, so remember that this included high bleeding patients and ACS patients, you can see that there were clearly a higher percentage of cardiovascular endpoint, particularly stent thrombosis in ACS population. Now, so there were fewer. So the bleeding event rate was 4%. So which was as expected. So it was not lower. However, if you look at the stratification, you can see that GI bleeding was less, and also ICH bleeding was less compared to the former trial, STOP-DAPT-2, which used the same definition. So there are some points for discussion. So was it the dosage of Prasugrel? So we used 3.75 milligrams daily for, and also 20 milligrams for loading. That's approved in Japan. So was that too low? That's probably like 1/3 of the dosage used in Europe or other countries. Or are we already there? I mean, we have been struggling with bleeding and thrombosis and the balance between bleeding and thrombosis, but have we set enough for bleeding that everybody is taking care of patients much better now and there are less bleeding in critical sites? Do we really have to care more for bleeding at the risk of thrombosis? And what is the impact on other ongoing trials? There are many other trials that are ongoing that are trying to minimize the use of antiplatelet in ACS or other subgroup patients. So is it ethical to really continue those trials, or whether since they are using a different antiplatelet, should we have more data? But what if there are some other different outcomes that is seen with these ongoing trials? How are you going to interpret? So that's for the discussion.
Thank you very much. Kind of surprising results. That we did see a slight increase in the thrombotic events, while there was no significant reduction in the bleeding events. So what's the take on this, KW?
Yeah, so it's a very large study. I think it was almost 6,000 patients. So it's a pretty large study. But I think the first question to ask is, the completely aspirin-free strategy. Now, is that going to work? So in this trial, the answer is no. You need to have a certain period of aspirin. But I think this study does not completely answer that question. So we can't really say from this trial that the aspirin-free strategy is we can't even go forward with that, because I feel that with this trial, the big difference is, as you mentioned, the dosage of Prasgrel. So usually in most Western countries, it's 60 milligrams loading and 10 milligrams of maintenance of Prasgrel. In this trial, they used only 20 milligrams of loading and 3.75 milligrams maintenance, which is the dose that is used in Japan, but nowhere else outside of Japan. And I think that is a very big limitation of being able to generalize the findings from this study. Another issue that I think needs to be mentioned is the design of the study, that it was done within the first month. If you look at all of the other trials, most of the bleeding that occurs within the first week or the first month after PCI is mostly related to access site bleeding or procedure-related bleeding, and not bleeding per se from spontaneous bleeding per se. So usually when we are talking about reducing the risk of bleeding, we are talking about trying to reduce the chronic occurrence of bleeding, not the peri-procedural risk of bleeding. And so the time point that was looked at for this trial, the first month, it would be predominantly dominated by the peri-procedural bleeding and access bleeding, and not the actual bleeding that we are trying to prevent. So I think that the time period of looking at this, it may have been a better try if they said they will look at the events from 1 week and then after 1 week, and maybe maintain that for 1 year. Then we may have seen a completely different result in terms of bleeding. And also, the second part about this study is that they enrolled two very distinct populations. One was ACS patient who have very high risk of thrombotic events, and there was 25% high bleeding risk patient as well. So these are very, of course there is several overlap between the two patients, but actually we are talking about two distinct populations. We are talking about ACS patients and HBR patients. And so that makes it very difficult to tease out the results of this study. And because of that, we need to be really careful, because as you mentioned, there was a increase of definite and probable stent thrombosis. And also, if you look at just the ACS patients, the co-primary endpoint for composite cardiovascular outcome was almost significant for thrombotic endpoints as well. So,
yeah, very good criticism. Arintaya, any comments? Any final word?
I do like the idea of having our own dosage for the Asian population for any medications. But I'm just wondering, the 3.75 from Prasgrel derived from pellet activity study or any study?
There's a Japanese study.
So Prasgrel was developed by Daiichi Sankyo, which is a Japanese company. So when they did their pharmacokinetic and pharmacodynamic data from phase 2 trials, they understood that the 10 milligrams of Prasgrel was a much, much higher dose in terms of efficacy compared to clopidogrel. So usually when we are talking about equipotent dose, maybe 2.5 milligrams of Prasgrel is similar to 75 milligrams of clopidogrel. So in Japan, from the beginning, they had a lower dose. And if you look at any drug, always Japan has the mini dosage as well, always.
But I have to say, that 3.75 came from Prasgrel plus aspirin. So I was wondering, maybe we should have looked at Prasgrel, yes, alone as a monotherapy, and maybe we could have come up with a different dose.
Okay, it's almost time, so we have to wrap up. So now ESC goes on until tomorrow, and so there will be many trials presented here at the ESC. But so enjoy the rest of this conference. Thank you very much for your attendance.